Morning. Morning, everybody. Episode 224. Active and passive structures of the knee. Welcome back if you're joining us again. Looks like we've got a few people live. I'll just pop a note in the comments. If you want to drop a comment in, it looks like everything's working. So we will get going. Good morning. Morning, Webbo. Happy Anatomy Monday to you. Yeah, good trip. Thank you. Yeah, I think it took me till I arrived back Monday at about midday UK time, and yeah, it was pretty tough last week. Yeah, I've learned that from previous trips that definitely don't work on the same day when you come back. That's not a good idea, and also the day after now. So yeah, it wasn't too bad. I didn't go back into clinic until Wednesday, so that was good. Morning, Dave. All good, thank you. Hi, Rahul. Good to see you. Good afternoon to you. So let's get going. We finished last time. We finished on the meniscus. We were looking at that. So I just want to do a little bit of a recap, and then we've got a couple of other passive structures to look at, and there, especially if you're doing clinical assessment, that kind of thing. So yeah, just wanted to add those into your mix for your clinical reasoning. We were talking about this on the weekend. So the more information that you've got, the book smarts, if you like, to add into the mix for your clinical reasoning, the better your reasoning will be, and also the easier you will be able to refer people if you haven't got a clue what's going on. So I think sometimes, again, we were talking about this on the weekend, where if your clinical reasoning is limited to whatever you've learnt on your initial course. So if your initial course was initially talking about muscles and joints, and it went into depth about that, then that's brilliant. But if it's missing the nervous system, or it's missing the lymphatic system, or it's missing visceral organs and referred pain from either the somatic referred pain or visceral referred pain, then you only have a small slither window of what you can consider when you're looking at someone who's got an injury or pain or whatever it is. So there are many different things that feed into the mix, and obviously things that even I haven't heard of yet, and I'm yet to discover. So I think we just have to be a bit humble about stuff, and you can't be 100% sure all the time. In science, that's not the case. We're kind of like 99.9% certain with some things, but being 100% is pretty hard, because we don't know what we don't know, and that's what I hope to add on some things that you don't know this morning. Morning, Tris. Good to see you. Morning. Right, let's have a look at this then. Not that one. That one. Quick recap. Cruciate ligaments. I talked about a way to remember them for your assessments. So if you're doing an exam and you have to locate the ligaments, and you're like, I can't remember which one goes which, then or which one starts where and ends where, then you can remember LAMP. Hopefully this will help you. LAMP. So we've got, let me just grab my arrow there. We've got the lateral aspect of the femur, is where the ACL attaches, and it's the LAMP opposite. Okay, so if it's lateral femur, so you always start on the femur with the first letter, and so the lateral is the ACL, and it attaches onto the medial tibia. Okay, and then the medial femur, which is the PCL, attaches onto the lateral aspect of the tibia. So that's your way to remember those. And then we had a look at some pictures of this. So there's your ACL just there, so that you can just about make out the fibula head down here, and the LCL. Well, from the text there, that's pretty obvious. So this has to be the lateral aspect. This is where the ACL originates from. So there's the lateral femoral condyle. This is the inside of that condyle, and then it attaches down here onto the medial aspect of the tibia, and it's at the front. Okay, so the anterior cruciate ligament is front of the tibia, and what it helps to prevent is an anterior translation of your tibia, so that forward shearing motion. And we were talking about the kind of rehab for that, or prehab even. So if you know somebody who plays a sport where ACL injuries are really prevalent, then we can start doing some preventative exercises. We were talking again about some things you can't prevent. So if you play a sport where you're going to get clattered into by an opponent, and they kind of lock up your knee, or it locks in the ground and it twists funny, there's nothing really you can do about that. You can't prevent those kind of injuries. But what you can do is the ones where it may be a control issue. And a classic one was Michael Owen. This is years ago, and there was no one near him. He just went to change direction, and his knee just twisted and buckled. And so that kind of non-impact injury we may have an effect on. Okay, so we can work because these are passive structures, so we can train the active structures to support those passive structures during their role. And if you think about the direction of translation of the tibia is anteriorly, so going forward, then the muscles that stop that attaching onto the back of the tibia and the fibula are your hamstring muscles. So if you've got somebody who's had an ACL injury, or you're trying to help reduce the risk of hamstring injuries, training the hamstrings, ACL injuries, then training the hamstrings is a really, really good idea. Okay, so I think I said that the wrong way around. So ACL prevents anterior translation, and if you want to reduce the risk of that ACL injury, train the hamstrings. Okay, it's a really good idea to do that. However, it needs to be, well, it doesn't need to be, but it's useful to be near the joint that you're training. So we were talking about this on the weekend. So if you want to exercise the area of the hamstrings that help the knee, then really we need some knee focused hamstring exercises. So something like a Nordic curl, hamstring curls, those kind of things. If you want to do a hamstring exercise that is more hip focused and pelvis focused, then you do things like deadlifts. Yeah, so you can work the hamstrings from both ends. And one of a really good exercise, especially for eccentric control, so lengthening control, is a Nordic curl. So if you haven't seen those before, in fact, we've got a whole video of those on our YouTube channel. We've got loads of different variations of it as well. So if you type in Nordics on the musculoskeletal education channel, then it'll come up with those. Good idea to do those if you're involved in that kind of work. This is the PCL, so the posterior cruciate, and that was from the medial femur, and then it went onto the opposite, so it goes onto the lateral tibia. So again, there's the fibula head just there. This is the PCL, so medial aspect of the condyle of the femur. We talked about the bony landmarks a couple of weeks ago. And then there's your attachment point on the back of the tibia. So this will help prevent the opposite movement, so a posterior translation of the tibia, or an anterior translation of the femur, whichever way you look at it. One's going one way, one's going the other. With that one is less likely to happen. It's very rare that you get PCL injuries, unless again you get battered into. So if you're playing rugby or football, and you obviously wear studs in those games, so your foot is planted, studs are fixed in the ground, someone then comes to tackle you and goes really low and tackles your shin, your body is going forward but your shin is going backwards, that's the kind of thing that will injure your PCL. Okay, so yeah, a little bit less likely to occur, that one. And then we looked at the meniscus as well, and the innervation of these and the blood supply to these. So we were looking at the differences between the outer portion and the inner portion. So you can have some meniscal injuries and you don't even know you've got them because it's in an area of the meniscus that is poorly innervated. So, but what you may get is locking. Okay, so if there's a flap of meniscus that has been broken off, as you're moving your knee, as the femur is gliding over the tibia, it can lock. Yeah, and again, you don't know that you've done it. You might have had some pain at the time, bit of swelling maybe, but you don't know. It doesn't hurt, but it locks. Okay, so that's a classic one. Morning, Caroline. No problem. Yeah, yeah. We were talking a bit about Tris on the weekend. Yeah. So it was all good, Tris. Definitely. Yeah. So all good. So this is the shape of the meniscus. And on ultrasound, you can see this to a certain extent. You can get down probably to about here. Yeah, you can't see right on the inside of the knee joint with ultrasound. You'd need an MRI if it's something deeper in the knee. But certainly you can see here. We were talking again, if there's an injury to the inside of the knee, fluid can leak out of the joint capsule. We'll have a look at that in a second. And it can trickle out and then down here, so in between the ligament and the bone, and that can be really, really tender. Okay, because obviously it's got nowhere to go, so it's pushing on the underside of the ligament, pressing into the bone as well, and the bone, the periosteum around the bone is highly innervated, so that can be quite sore too. So we were talking about that, and the innervation being in the outer part of the meniscus. So yeah, we've got 3 nerve endings except the inner third of the meniscal body. So that inner portion is the bit that you can injure and you don't know. Okay, but saying that, usually if you injure it, there is something else as well, which will then cause an inflammatory response. But that may be short-lived, and then that calms down, and you think, oh, it feels okay. But then you get this abnormal clicking, locking, that kind of thing. Okay, we went through that last week. And this as well. So the purpose of this picture is to show you the different fiber directions of the meniscus. So obviously your knee twists and flexes and extends. So it needs to have, the meniscus needs to have integrity in all different directions. If the meniscus only went round in a circle and you twisted your knee, it would just open up the whole of the meniscus. Yeah, because it wouldn't have any integrity to resist that kind of movement. So if you've got different movements going on, then we need fibers in different directions so that we can maintain the integrity of that meniscus. Yeah, they're not static, they're mobile. And just want to show you this as a quick recap. So this is the meniscus, and there's a good bit on here that shows the mobility. I think it's this one. So these are your condyles of the tibia. There's your fibular head. So this is the lateral condyle, that's the medial, and then here are your menisci. So they're not static on that plateau. They do move around. Well, one less so than the other. But there's your O shape for the lateral and a C shape for the medial. And there's that wedge shape of it from outside to in. So thinner in the middle, flatter on the outside. So they attach onto this interarticular notch. We've got the medial attachments on the medial meniscus are far apart. These ones are closer together. And then we've got attachments to the joint capsule as well. And we'll have a look at that when we look at the capsule itself. So there you can see the attachment. The joint capsule has been cut there, so you can't really see it very well. But here's the movement. So there's the lateral one. The medial one doesn't really move that much. It does move. That's wrong, really. It shouldn't say that. It does move, but not very much. Not as much as the lateral aspect. Okay, and the movement helps to produce synovial fluid. Yeah, so if you have a static knee for a very long period of time, then it's a good idea, even if they can't actively move it, that you can get some passive movement to try and get that stimulation of the synovial fluid. Helps with the nutrition to the joint and movement of the joint. Cool. So that's the meniscus and the ACL, and these are we didn't get this far, so this is quite good to see. So we've got the different types of meniscus injury. So if you read an MRI report, you might see these come up on the report. So we've got a radial tear. That bucket handle is quite a common one to hear about. Oh, I've got a bucket handle tear of my meniscus. That's what it looks like. It is literally like a bucket handle. Okay, so that hence the name. That these ones can lock. Obviously, if you've got that flap of meniscus and you get into a certain position and it flaps over, then as you try to straighten or bend your knee, it can lock in position, and that's often what people complain about if they've got a meniscal injury. We could have a horizontal tear. Okay, so from that wedge shape, so coming through the meniscus. A parrot's beak, again, you might have heard of that one. A root tear, so this is the roots of the meniscus. And then a degenerative tear, which is kind of normal wear and tear, if you like. Menisci are not pristine as you age. So just as we age on the outside and we go a bit grey and we go a bit wrinkly, the meniscus does the same. Okay, so the tissue is not as pristine as it was back in your teens. As we get older, you will have degenerative changes in the meniscus, which are entirely normal. And if you scan knees that are asymptomatic, so they have no problems at all, you will see degenerative changes in the meniscus. Yeah, they'll be identified on MRI. The problem that we've got is that people who don't have pain have changes, and then if someone does have pain, they go for an MRI and they see changes, and you go, well, is it normal or is it pathological? And they're the reason for the symptoms, or maybe they're not the reason for the symptoms and it's something else. So sometimes it's a bit harder than just going, oh, if you've got a radial tear, you will have pain. It's not always as simple as that. Okay, right. Joint capsule. This is a good one, I think, because I think we forget about this. Again, passive structures, so it doesn't have any active role. This is inflated, yeah, to highlight it. It extends underneath underneath your quadricep muscles. So these are your quadricep muscles here. There's your patella. So if there's an injury to the inside of your knee and swelling starts to occur, then this capsule will start to fill. And if you have an inflammatory condition or an injury, then you'll notice this swelling. When you push on the patella, it will be like a boat in the sea, so it will bob. Yeah, and normally you don't get that kind of bobbing effect, but if you're pushing down on the patella and it bobs, then you're like, and it's kind of squishy, then we know that there's swelling underneath. Again, if you're doing ultrasound scanning or you get an ultrasound done, then you can easily see fluid, and especially up here. So this we call this the suprapatellar area because it's superior to the patella. So all that area there, and also classically at the back of the knee, and this is a popliteal or a Baker's cyst. Yeah, and you may have heard of those. So these pop out the back, but sometimes they're not there, but you have swelling elsewhere. It's kind of distributed elsewhere. So it all depends. This fluid can leak out the side, as I was saying as well, and can drip down behind the ligaments, and especially the medial collateral ligament. And again, we talked about that last week. So if you notice swelling and the joint capsule is really swollen, then you can do a couple of little tests. There's a test, again, Google this one. It's called the sweep test, where you push fluid upwards, so you're trying to collect it into this suprapatellar pouch up here, and then on the lateral aspect of the knee, so you sweep up on the medial aspect, and then you hold it there, and then you sweep down on the lateral side, and then that pushes the fluid, forces the fluid down into this part of the knee again, and you'll see a little bulge come out on the medial side if there's significant swelling there. Some people are better at doing the test than others, and they can detect even the tiniest amount of fluid. But if you've never done it before, have a look on YouTube. There are some videos where they show a positive sweep test. So yeah, you push up, hold it, and then push down on the lateral side. So you're just pushing that fluid down, and then the fluid will pop out on the medial aspect of the knee. So what I would do, that we wouldn't know what was going on unless it was obvious. So you do your ACL, PCL tests and meniscus tests, but sometimes they're all negative, so we don't really know what's going on in the knee. So I get that investigated further, get some imaging. But that's why it happens. So something is irritated inside that capsule, and then the resultant edema is filling the capsule, and that's why your knee swells up. Okay, so that's a useful thing to know. Let's show you this. So this is the joint capsule. Okay, so there's your patella, there's your patella tendon, and this is the capsule, and it attaches onto your MCL. Yeah, just onto there. There's your LCL. So the LCL is free of the capsule. And there it is underneath there. So it looks very different to the picture. Yeah. So you look at that picture and you think, oh, it's like a little bubble around. It's not like that at all. It's this fibrous tissue that just kind of envelops the knee joint and molds all the way around the knee. So it's not like that, you know, that kind of blueness that we saw on the picture just then. So at the back of the knee, we've got a thickened part of the capsule to stop hyperextension, to help prevent it. And then here it's been cut, I think. Yeah, there we go. And there you can see inside. Yeah, so that's the synovial membrane of the knee. And just very quickly, I've put a little advert out because we're doing some dissections in London in December, and it's on the website. So if you want to have a look, but this is the kind of stuff that we see. Okay, so we'll dissect down to this level, and then you'll be able to see the capsule and dissect the capsule and see inside the knee joint. Okay, so this is the kind of stuff that we'll be doing on that particular dissection day. So this is the back of the femur, back of the tibia. There's your fibular head. Cruciate ligaments are in there. Okay, covered in synovial fluid. Yeah, so that's what the capsule looks like, which is very different to that. Okay, it's not just like this blue blob. It like I say, this one's inflated, so obviously it's not inflated in real life, so it shrinks down and wraps around the knee. Cool. Okay, and then yeah, so that's your Baker's cyst coming out the back. So if there's significant swelling on the inside, you can get a posterior bulge of the capsule, and that's called a Baker's cyst. All right, and so when you're doing a knee examination and you're looking at the front of the knee, the side of the knee, the back of the knee, these are the kind of things that we're looking for. We're looking for significant swelling, and especially if it's inflamed, it'll be hot and maybe red as well. So you have a feel around the knee as well to assess the temperature as well, and any kind of bogginess within the tissue. But if it's significant, then you'll definitely be able to see it. Yeah, it's you can see the difference between one side and the other usually. Another passive structure that, now this is a hard one to see. I can't remember whether I've got a video on this. Maybe on that one. We'll have a look at it in a second. But Usually the fat is dissected out when we're doing a dissection. But the Hoffer's fat pad is quite a useful one to know about. It fills this gap here. Okay, so there's your patella, there's your femur, there's your tibia. These are your meniscus, just here. We've got the capsule, which we've just been looking at, so that comes all the way around here. And then this fat pad here fills the space underneath the patellar tendon. Now, this is highly innervated, so it's got a lot of nerve endings, and it can get inflamed, and it can be really, really sore. And what tends to happen with this is it gets injured usually in like a hyperextension. Okay, so in that kind of position there. So if you have someone who has got high mobility in their knees, or if they've been involved in like a tackle or something like that in sport where their knee's gone into hyperextension, then as it goes into that position, that bit and that bit can pinch the Hoffer's fat pad. Okay, and you get this really soreness here, which when people point to it, you go, oh, that's the patellar tendon. Yeah, but the patellar tendon is more superficial. And so you have to work out, is it the extension that's causing the pinch and that's what's causing the symptoms, or is it the actually a bit more superficial and it's the tendon itself? Because if you try to rehab this and you follow the normal patellar tendon loading protocol, it may irritate the Hoffer's fat pad and it just doesn't go away. Okay, so it's another thing to think about when you've got someone coming in with anterior knee pain. Okay, so that's Hoffer's fat pad, or the infrapatellar fat pad, which will probably be known as from now on, because we're trying to get rid of the names of people. Cool, so that's Hoffer's, and in fact, before we go on to that, let's just show you this. So this is the patellar tendon. I can't remember if the fat pad is underneath this or not. Well, but I'll show you the space in which it is if it's not actually on there. So there's your patella, there's your patellar tendon, fibula head just there. Okay, so quadriceps tendon at the top, there's your patella, and it's that space there. Yeah, so that bit there is usually full of fat. It's not empty. Yeah, and that's where Hoffer's fat pad is, all in there. There's your capsule that we were just talking about. That's been cut there, so you can see the condyles. There's the other end cut there, or the other side cut. So there's your LCL, fibula head. So you can see the suprapatellar bursa just under there. So that's that pouch I was talking about underneath the patella. So, and that's how the knee all glides. I think that's worth seeing again. Hold on, let me just play that one again. Get rid of those. Okay, let's do this one. Okay, so quadriceps, so quad tendon up here, there's your patella, and then the patellar tendon just here. The patella sits in the tendon, so it's all enveloped, yeah, so you can get a tendinopathy anywhere on that patella. And in fact, that's a point to note actually. So quite often you'll see jumper's knee, so patellar tendinopathy, and it's said that it's around here, yeah, so on the apex of the patella where the tendon attaches. Now the tendon goes around the whole patella and is a continuation of the quad tendon from the top. You can get tendinopathy all across here, yeah, you can get it anywhere on the anterior aspect of the patella, so on the front of the patella, and you can get it on the apex. Yeah, it's not always here. So again, if you're getting someone in and they're complaining of anterior knee pain, feel around the whole patella, not just on that apex, because if you just do the apex and you go, well, that's not sore, can't be that, then you might miss it. Okay, but it can be anywhere all around there. I find that's quite common. So there's your patellar tendon, and that's the hole where Hoffer's is. There's the capsule again. There's the medial collateral ligament there, lateral collateral, capsule again here. So you can see the space there where Hoffer's would be. Suprapatellar, space for Hoffer's there. Cool. And you can just see how everything glides and moves when you flex the knee. Perfect. Okay, so that was Hoffer's and the patella tendon. So it's good to, well, obviously didn't see the fat there, but you can see where it would be. And then we've also got bursa around this region as well. There are quite a few. We've got bursa at the back of the knee joint itself, so semimembranosus bursa, and that usually sits between semimembranosus, semitendinosus to stop them rubbing against each other. You can develop bursa because if you've got this friction occurring, the body will build a bursa to help prevent the friction. Yeah, so I've seen that a couple of times when I've been scanning, gone, what's that? It's like, oh, it looks like a bursa, and it's got the kind of shape of it as well. So yeah, you can have semimembranosus at the back. We've got this subsartorial, so the pezantherinus bursa. You've got 3 muscles that attach into this point, and there's a bursa there because that area has got a lot of friction going on. Okay, so and we'll talk about that when we get into the muscles. We've got a deep infrapatellar bursa. So that's just, there's your patella tendon. It's underneath your patella tendon where it attaches onto the ischial tuberosity. So just there. A subcutaneous infrapatellar bursa. So subcutaneous means underneath the skin. So this is that's the skin line just there. So this is underneath the skin, but in front of the patella tendon. And then here's your patella. There's your subcutaneous, so under the skin, pre-patellar bursa, in front of the bursa. That one there. That one's a good one because that's a good one to Google. There's quite a few people with something called housemaid's knee. So if you kneel on the kneecap, it can irritate the bursa, and then that bursa just then gets inflamed and it swells up, and you've got massive knobbly knees. So you can have a look at that. It's very common with people who are working on their knees all day. So like carpet fitters, plumbers, that kind of thing. Yeah, so if they're in a cupboard, bending down, kneeling on hard floors, that's why they wear the knee protectors to protect their kneecap. Yeah, so but or it could be an impact thing. So you've been hit on the patella, front on, and then it will inflame the bursa. And then we've got the suprapatellar bursa up here. Okay, so superior to the patella, suprapatellar. Cool. So those are your bursa. On the other side of the leg, which you can't see, we've got an iliotibial bursa as well. So that's where the ITB comes down, and there's a bursa just underneath the femoral condyle to prevent the ITB from rubbing on the condyle. Right. So wherever there's friction and compression, you'll usually have a bursa to prevent the friction. And I don't think I have anything here, but if you imagine, if you rub your hands together and you keep rubbing them for about a minute, they'll get really hot. Yeah, so imagine that running. Yeah, so we've got things gliding across each other as you're running. If you have a water bottle or something cylindrical in the way of your hands and it creates a bit of a gap, you can do that movement and it will create no friction. And that's basically what a bursa does. Yeah, so it helps to minimize the friction between these 2 surfaces. But usually if you land on it or get it hit or squash it and rub it and irritate it, it will start to swell, it will get inflamed, and then it will push on the other structures that are around. Okay, so that's quite a classic one. Perfect. Just check, see if there's any other here. Yeah, let me show you this. Probably one of the things that is mistaught the most in courses is the ITB. So the ITB, before we get into the video, is not a band. It is a thickening of the fascia of the thigh. Yeah, so that the ITB wraps around the entire thigh. It's not just this band that runs from your pelvis down to your tibia. Yeah, so let's just have a look at that. Plant that seed before you see the video. So that is the fascia lata. If you like your coffee, A latte is milky. So this is the white fascia. Yeah. It wraps around the whole leg, and it also extends below the knee and covers the whole leg. It's the superficial fascia. It's not just in certain pockets, it envelops your whole body. So when you dissect away the skin, you'll see a fat layer and the superficial fascia. Okay? And that will wrap around and cover everything. You can see, though, these areas here. So the TFL is the, if you've not heard these muscles before, is the tensor fascia lata. So it tenses the white fascia. Yeah, so that's what that does. You've also got a massive muscle around the back here that also connects into your fascia lata, which is called the glutes. Okay, so you've got your glute maximus muscle, the big glute muscle, and the TFL, tensor fascia lata, both join together and then attach into this connective tissue. And what happens when you put stress through the body is it will lay down more tissue. So as you develop and as you start to walk and then start to run and you do more and more activity, your glute and glute maximus and your TFL will be contracting all the time to move your leg around. And that contraction and that pull on this fascia lata will create a thickening of it. And that thickening is dissected out, and in all the textbooks pretty much you will see it like this picture here, and you think, oh, it's just this band down the leg, but it's not. It wraps around the whole leg. Okay, so that's what it looks like in real life. So there's the fascia lata all the way around. There's the hamstrings under there as well. So that's the posterior aspect of the knee. There's your patella. So it covers the whole thing. And this bit is the iliotibial tract or iliotibial band. It's the thickening of that connective tissue. And then it comes down here onto Gerdy's tubercle, which will no doubt be renamed at some point. So there's your IT band that you see, like that picture there. Yeah, but that is just the thick part of what wraps around the whole leg and keeps it all in place. So this is that connective tissue, that fascia, is like wearing a pair of skinny jeans. Okay, so if you've got skinny jeans on and keeping everything tight, yeah, that's exactly what that fascia is like. Right. So you can see the quadriceps at the front. There's your patella. There's your vastus lateralis. These are your hamstrings at the back, biceps femoris. And that there, that's really cool. Okay, let me just pause that there. That's the lateral intermuscular septum. So lateral means to the outside. Intermuscular means it's in between the muscles. And a septum is a divide. It's a hedge. Okay, so if you imagine a farmer's field with lots of hedges, those are septums. Okay, dividing the field up into sections. That's exactly what happens here. So that lateral intermuscular septum attaches onto the femur, and it creates a compartment of the thigh. Yeah, so just like in the lower leg, where we had compartments of the lower leg, we've got compartments in the upper leg as well, so in the around the thigh, and we're going to have a look at that in a second. I'll do that before we finish today. So there's your IT band, there's your biceps femoris, that's where your IT band attaches, so that's where the thicker part attaches. There's your gluteal muscle, so gluteal maximus, and there's your TFL around the front there. So all of that is attaching into, well, not all of it, but there's a large proportion of it that attaches into your IT band. There's your tensor fascia lata there. So that's where TFL attaches on the iliac crest, and then it inserts into the fascia. Okay, hopefully that was useful, because it's very different to what we get taught. Right, let me just, I'm just going to skip over that and those. I want to get to this. Here we go. So we'll do this and then we'll go back to the bits I've just skipped over next week. This is a cross section. So imagine cutting off someone's leg and having a look on it, end on. There's your femur. Right? The skin is around the outside, and then if you have a look here, this is the IT band around the outside here. Yeah, so this is a left leg, And all of this blue area here, this is the anterior compartment. So it's the front compartment of the thigh. All of these muscles are grouped together, and they have a blood supply and a nerve supply that supply the anterior compartment. Very, very similar to around the tibia, okay, and that compartment, the different compartments we were looking at in the leg. This bit here, which is pinky, I think it's pink. I'm a bit colourblind, so I see it as pink. This is a posterior compartment, okay, all around here, and that posterior compartment has got the sciatic nerve in it as well. Okay, so that's these muscles all here, and what we'll do, we'll look at all the muscles in their compartments. This one here is the medial compartment, yeah, and that's the green zone there. So this is where all your adductors live, around here. Okay, so that lateral intermuscular septum, if we come around here, there's your IT band, all the way around. There it is there. So see that there's the word in there. So, and can you see it comes back there, attaches to your femur. So this is like, if you remember my analogy before, Trivial Pursuit wedges. Yeah, so again, if you don't know the game, Google it. Trivial Pursuit wedge. It's like these, you've got the circle around the whole leg, and in the thigh, you've got 3 wedges. One at the front, one at the back, one on the side. And all of those are sectioned off by these septums. There's the medial one there. Yeah, there's the posterior one there. But they all attach to the fascia lata, which wrap around the whole leg. So you got the whole leg encapsulated by this connective tissue, and then every section is as well, and they all go in towards the femur and connect onto the femur. Yeah, so it's exactly the same as the leg, but just bigger muscles. Cool. And that, we'll call it a day there. Good timing. Right. So next week we will get onto the muscles in a bit more detail. Yeah, so we've done all of the passive structures now, and we'll start to look at the compartments. There's a couple of little bits that you've just seen there. So we've got some muscles that cross the knee, but they're from the leg. So we've covered those already in the ankle and the foot, but we haven't had a look at the knee portion of them. So we're going to add those on. So like gastrocnemius, popliteus and plantaris, I think. So we'll have a look at those. And then once we've done those, we'll then start to move on to the compartments of the thigh, and to show you what muscles are in each of those. Cool. I'll see you next week. See you Monday at 10 a.m. GMT. See you then.